Hi, welcome to Askimo TV. I'm talking today to Dr. Vel Sakthivel. Dr. Sakthivel is the lead doctor for the Department of Children's Orthopaedics at the University Hospital Southampton in the UK. He specializes in children's orthopaedics and sports injuries around the knee. Hi, Dr. Sakthivel. How are you?
Hi, Joanne. I'm fine. Thank you.
Great. Dr. Sakthivel, let's talk today about foot abnormalities. Are foot problems common in newborns, and why?
The foot abnormalities are very common in the newborn, and if you have friends or family who have children, if you ask them, they always say that the foot doesn't look well, it's a bit turned in, a bit turned out, and things like that. I use the word always. I don't use the word always, but in this case I have to use it because I've had babies and families come to me and say, well, the foot is a problem, doesn't look like that. The sense is, as in my previous interview with the hip dysplasia, it is all a packaging, how well they are placed in mummy's tummy, how they are squashed and things like that. The foot is a very interesting structure because it's got, although the size is so small, it's got loads and loads of bones in it, okay? Probably about 20 bones in it. And it's got so many joints with each bone. And so it works as a complex structure, although it's one part of the anatomy, it does work as a complex structure. And because of that, the tendency for the newborn baby is for the foot to be in a very different position. The leg is itself twisted, so the foot more often than not point inwards, okay? It is mobile, and that's what we need to identify. You need to make sure if it's correctable or not. But the answer to your question is there are abnormalities, not abnormalities, there are different positions of the foot which may look like abnormalities, but they're essentially not. It's just how the baby is formed inside mommy's tummy. This is for the newborn. And as they are getting older and older, a slightly older child, then there are other issues which we can speak about.
What are some of the foot problems that a newborn could have?
The most common problem is what we call forefoot adductors. Now that's a complex word, and don't get confused by it. It essentially is the front half of the foot is pointing more inwards than to be in line with the back half of the foot. That's one of the abnormalities. The other abnormality, which I'm sure most of your viewers would have heard or known or be familiar with, is the clubfoot. It's called CTEV, congenital talipes equinovarus. That's the fancy word for it, but in short we call it CTEV. Members of the public call it clubfoot. Now that again is a very complex deformity to describe in here because there's about 3 different deformities in the front, in the middle, and the back half of the foot. And it essentially is the foot doesn't point in the right direction, and the sole of the foot doesn't form, is not parallel with the ground. These are the 2 main issues, okay, in both these different conditions. But combine the 2 together, they form most of the abnormalities in the newborn foot.
So with these 2 abnormalities that you've mentioned, what would the treatment options be for each of them?
Because they're newborn, and as I said, the feet are more often than not subtle and mobile, they usually get treated well with stretching and casting. Ponseti casting is what nearly all pediatricians who specialize in foot problems do. It is basically a method of serial casting where the cast is changed every week with the foot in different positions. So if the foot is pointing in, for example, every week we change the position of the foot to make it form or make it point in the right direction, thereby gradually stretching the tight muscles which initially cause the deformity to start with. And very rarely this can happen, this can go on for more than 5-6 weeks, but usually within 6 weeks we tend to get a good position of the foot. On top of it, again, sometimes we have to release surgically one of the tendons in the back of the heel. This is not a complex procedure, but with these combined methods, the success of treating clubfoot is now close to about 95%. And this is no complex surgery or anything like that involved. The key to this treatment is the initial part, which I just described as conoscetic treatment, which is serial casting. Subsequently, after that, you need a little bit of support with what we call boots and bars. So you need to put the foot in a splint, for example. Okay, that's the shorter way to describe it. In a splint for some time, and then after that, we're looking at a kind of a booty type shoe, not these flimsy, canvasy type, soft cloth shoes, but of a booty type shoe which kind of holds the foot or gives the foot a little bit more, control and stability for some time.
What would happen with children long-term who've had foot abnormalities when they're younger? Can it have any effects later on in life?
It can. The essence of our treatment is to get what we call a plantigrade foot. Now, that is again a fancy word, but essentially what it means is to get the foot pointing in the right direction and the sole of the foot parallel to the ground. Okay, and that means what we are aiming for is to get a well-functioning, painless foot. So if we get that, then we have reached our aim, and I'm sure that the patient, the child who's had this problem will be very happy. Occasionally what can happen is we fail in this attempt and we can get them a slightly stiffer foot with a little bit of pain. If we do reach this stage, then I'm afraid we have to think about other conditions or other treatment methods like surgery, where we physically have to identify the tight structure and release the tendon. We may also have to do a boning operation where we have to cut the bones and reset it in the right direction. But these are on the older child. I'm talking about probably sort of 10 years and up onwards. Okay, this is just a rough figure, but 10 years and onwards. It does depend on your treating physician or surgeon when they look at you and see how mobile the foot is, how fixed or painful the foot is, and things like that. And then more recently, we've got the external fixator, which is I don't know if you've seen, the frame which goes around like a scaffolding, which we place outside the foot, outside the leg. And we use that external fixator, it's called the ring fixator, and we use that to gradually correct the feet to the position where we want it to be. So these are the three main classes of treatment.
Thank you, Dr. Sakthivel. Thank you so much for talking to me today.
Thank you, Joanne. Thanks.